Welcome to the Motivational Midwife channel. I'm Lynn Jones and today we're going to look at sepsis. So we're looking at sepsis today, and you might find yourself thinking, why do I really need to know about sepsis? But sadly, it is still a cause of maternal death. So it is quite important that we know about sepsis and septic shock, which it will occur if we don't actually treat sepsis appropriately. So when I was looking for definitions that really suited what we were going to be looking at today, there are some very complicated definitions of sepsis and septic shock. But the World Health Organization, I felt, described it really well when they say it's a life-threatening condition defined as organ dysfunction, so the organs are not working properly, and that's as a result of some infection that's been picked up during pregnancy, childbirth, postpartum or post-abortion. Septic shock is what will happen if we don't actually treat sepsis appropriately. And septic shock is where you have persistent tissue hypoperfusion, so a lack of oxygen getting to the tissues despite the fact we have adequately replaced the fluid. So is it still a big problem? Well, actually 11% of maternal deaths were due to sepsis, either indirectly or directly, in the most recent MBRRACE report. So that's in 2020. And within that report, if you haven't read it, it might sound like it's a little bit of a dry read, but actually it's a really interesting read. And they give you examples of where, real life examples of where care has actually not been that good and how we've missed opportunities to have actually made things better for that individual woman. And often it's a systems and processes error, it's not anybody's individual fault. If we think back to the confidential inquiry back sort of 2006, 2008, nearly 25% of maternal deaths were due to sepsis. And the 2009-2012 triennial, 83 women died of sepsis. And of those, 20 of those women, it was genital tract infections due to group A strep, so a gas infection, which I'm sure you will have had some information on. And if you haven't, I would strongly suggest you investigate about group A streptococcus, because it is really quite a serious infection. And many of our women do have genital tract trauma, so they've got perineal trauma, they've got vaginal trauma, so they have got a direct route into their bloodstream. The current MBRRACE report actually highlighted some key issues that we really need to address, and that is timely recognition of sepsis or potential sepsis, really timely administration of IV antibiotics, and a quick involvement of your senior multidisciplinary team. They also highlight that it's really key that we be it antenatal or postnatal, if anybody presents unwell, that we do a full set of observations. And sometimes we're not very good at that in midwifery, doing an absolutely full set of observations. So that includes your oxygen saturations, your capillary refill, not just your temperature, blood pressure and pulse. And most importantly, respiration rate, because that will be one of your key symptoms or key signs that something is not going well with a lady. So let's have a little recap on that pathophysiology of septic shock. So what's actually going on in the body? Normally we have our blood vessels, they've got good tone, and they are sending the blood around the body quite nicely, and it's full of nice red blood cells that are diffusing oxygen and nutrients to the tissues. When we have infection, and infection is usually within the tissues, it's not often in the bloodstream, the body releases white blood cells to deal with that infection. And the job of white blood cells is to really find those pathogens and destroy them. And it does this in a number of ways. So the first thing it does is it calls on backup. So it calls for more blood cells to come to the area where the infection is. And then those white blood cells need to get to where that infection is. And we've already said it's in the tissues more often than not. So there's a number of ways that it can get what it needs to do out into the tissues. It releases molecules and enzymes into the bloodstream, such as nitrous oxide, and they interact with the blood vessels, and they cause a number of things to happen. The first thing that happens is the blood vessels become wider. They dilate. So we lose some of that systemic or that vascular resistance in the area where this is happening. And this is very often because the blood now is going to go slower in this area where there is vasodilation, where those blood vessels have become wider. The blood flow will slow down, and you will find that there is warmth in that area. So if you think if you've ever had an infected bite or something, when you put your hand over it, it is quite warm. And that's because in that local area, you have got this vasodilation going on and the blood flow has slowed. The second thing that happens is the blood vessels become leaky. So fluid starts to leak out of the blood vessels into the interstitial spaces. And this build-up of fluid in the interstitial spaces makes it very, very hard for oxygen to diffuse across to the tissues. So this is where you start to get your tissue hypoperfusion. And if you think back to our definition, our septic shock definition is where we have persistent tissue hypoperfusion despite adequate fluid replacement. And the other thing that will happen is because white blood cells' job really is to destroy those pathogens, the enzymes and molecules that they are sending out to help destroy those pathogens also damage the blood vessel walls. So this damage to the blood vessel walls triggers the body to release coagulation factors, so it's clotting factors, to try and repair that damage. So you get lots and lots of little micro clots developing. And if it's in a local area, localized area, that's not going to have too much effect on the body generally. But if this is happening systemically through the whole body, so you have this vasodilation through the whole body, and you have this fluid leaking out into the tissues in the whole body, and you also have damage to the blood vessels in the whole body, those clotting factors very quickly become used up, and the blood can start to spill out of the blood vessels, and they can develop something called disseminated intravascular coagulation, and the blood is just not clotting, and it's not really, it's quite a poor sign. If we see this, we know that the body is not in good shape if we've reached the DIC point. There's the little clotting factors just been released. Now that loss of systemic vascular resistance through the whole body, because cardiac output and vascular resistance are what is needed to maintain blood pressure, if you have a loss of vascular resistance through the whole body, eventually you are going to have your blood pressure start to drop. And this damage to all the blood vessels is also going to be happening in all the organs, so such as the lungs and the heart. So it is going to have an impact on oxygen absorption and cardiac output. So there's a little whistle-stop tour of the pathophysiology of sepsis. So what signs might lead us to recognise that sepsis may be developing or some sort of infection is developing? So as I've said before, your respiration rate increasing is usually one of your first signs that something is not right. So tachypnea would be the correct medical term for it, but it's your raised respiratory rate, and our normal respiration rate is somewhere between 12 and 20. Women in labour may have the upper ends of normal because obviously they are in pain, they're stressed, but you don't just put that down to labour. Look at the woman in a holistic manner. Certainly respiration rates of more than 24 a minute is a worrying sign, and you should be doing a full set of observations on her to make sure there is nothing else going on. Hypotension, so low blood pressure, is, as we've said in many times, it's not a particularly quick sign that something is wrong. It's usually quite a late sign that there's a problem. But if you have a systolic blood pressure, so that's your top figure that's less than 90, that is a worrying sign in someone who had that's not their normal blood pressure. Tachycardia, or increased heart rate that's more than 100, should alert you to doing a full set of observations to make sure there is nothing else going on there. And pyrexia, so temperature, if you've got a temperature that's higher than 38 or lower than 36, and often we don't think about those lower temperatures as being a problem, but they actually can signify that there is infection somewhere. Low oxygen saturation levels, so if they have got less than 95%, and you're only going to be able to do this by putting an oxygen saturation monitor on, if they've got less than 95% when they're just breathing air, then that is telling you that something is not right, they are struggling to oxygenate their tissues. There may be rashes, so little red patches, or they just may be generally red, or there may be little petechial hemorrhages, so they're like little red dots. The skin may change colour, it might be quite mottled, it might feel clammy. Your capillary refill, so your peripheral perfusion, so that's the oxygen and blood getting to the tissues, the peripheral tissues, it's often increased, so it's more than 2 seconds. Normally, if you place a finger, press for about 5 seconds, usually on the sternum, and then release, it will blanch, so it'll go quite pale or white, and within those 2 or 3 seconds, the colour should return quite quickly. If it doesn't, it's telling you that there is an issue with your peripheral perfusion. They might become quite anxious or confused, and this will be because of the decreased oxygenation to their brain. And obviously, if we have got tissue hypoperfusion, you are going to have organ dysfunction, and the first organ that usually shows signs of there being a problem is our kidneys, so reduced urine output. And if you've watched the video on shock, then you would have seen that we really should be looking at 0.5 mils per kilo per hour as an accurate urine output for an individualised care plan. So what symptoms may somebody present with? Well, they might have rigors, so that's like a real shaking. They may have diarrhea, vomiting. They may have pelvic or abdominal pain. They might just have a sore throat. They may have a productive cough. So this means they're actually coughing up phlegm, and that phlegm may be greeny coloured, or it might just be white. But it is that real productive cough. They may have some offensive vaginal loss. There may be obvious urinary symptoms, so signs of a urinary tract infection, so burning, stinging, frequency, blood in the urine. They may have an upper respiratory tract infection, so cough, cold, tightness in the chest, or an obvious wound infection where you may see signs of sort of pus or exudate coming from a wound. So what risk factors might impact on the risk of sepsis? And a lot of risk factors, it's not the risk factor in itself that causes the problem, but it's what it predisposes the women to. So looking at obesity itself doesn't make her more likely to become septic or more prone to infection, but the fact that obese women are more likely to have diabetes in pregnancy, that can impair their ability to heal as well. Any women who have got impaired immunity or are on immunosuppressant women, so our HIV women or women who have had transplants of any kind. I mean, years ago, these women would never have got pregnant, but now we do see women who really are quite poorly medically becoming pregnant. Anemia in itself, again, doesn't make somebody likely to be septic, but actually their resources to heal are reduced. If you are anemic, you're the nutrients and oxygen carrying capacity is reduced. Any vaginal discharge. Now, vaginal discharge in pregnancy, we know is normal. You get an increased vaginal discharge in pregnancy, but if it's offensive, if it's a bit smelly, if it's irritant, so if it's itchy, anything like that, then really we should be taking a vaginal swab, or advising the women to certainly get checked out in pregnancy. If they have a history of pelvic infection anyway, they're quite prone to pelvic infection, we need to be marking that on their notes, so it will highlight to us that there's a potential risk there. And obviously any invasive procedures that we do, so amniocentesis, vaginal examinations, particularly in the presence of ruptured membranes. If we are not careful with our aseptic procedures, our aseptic technique, then we risk introducing infection. Catheterization, about 65% of hospital-acquired infections are due to the insertion of a catheter. So really, we need to be very, very good at our aseptic technique when we are doing any sort of invasive procedures. If we've got any retained products of conception, obviously, so women who've had a miscarriage potentially, or membranes or placenta that's been left behind, that has the potential to be an infection risk. Cervical cerclage, this is where they put a stitch in the cervix, and it's usually for women who have recurrent miscarriages, and they do it reasonably early in the pregnancy. I can't remember exactly how many weeks it is, but it's a surgical procedure, so they will go to theatre. But again, it's an invasive procedure, so infection is a risk with any sort of surgical or invasive procedures. Prolonged rupture of membranes, so we've got that protective layer that was around the baby is not there, so we have potentially the risk of ascending infection. Instrumental births, again, instrumental birth itself is not specifically a causation, but again, it is an invasive procedure. You're also more likely with an instrumental birth, particularly forceps, to have an episiotomy. So then we have got an open wound there that will need to be stitched, and all of those things present an infection risk. Any sort of trauma to the vagina or the perineum, it's an infection risk, as is any wound anywhere. Hematomas that may develop, or abscesses, they can become infected quite easily. And obviously cesarean sections, and emergency is obviously greater risk than elective, because with an elective cesarean section you have time, you can prepare things very well. In emergencies, that's all happening a little bit quicker, and sometimes that may increase the risks for infection. And group A strep we've talked about a little bit, but really in close contacts, so family members. Particularly, group A strep is a bug that lives in some people, particularly in the throats, quite happily. It doesn't cause them any problems at all. But for our pregnant women, so if they have other small children who get coughs and colds, and they might be wiping their nose, and then they go to change their pad, if they don't wash their hands before they go to the toilet, they may have that, those bugs on their hand, and they change their pad. If they've got any sort of perineal trauma, they risk potentially introducing that infection into themselves. And Black and minority ethnic groups seem to be much more at risk of severe infection. So how are we going to manage it? Well, septic shock would be your emergency. From an emergency perspective, septic shock is a time-critical emergency. Sepsis itself, if you are suspecting sepsis, you have that 1 hour window to really get your sepsis 6 care bundle underway. With septic shock, we need to move equally as quickly, but we need to stabilize her first. Okay, so we need to stabilize her, manage the shock, and then look at what's causing it. So as with all emergencies, we need to call for help. Okay, we can't do this on our own. We need a multidisciplinary team approach, and that is highlighted in the current MBRRACE report, that we do need to get that senior involvement quickly. So we're looking at our registrar and our consultants, not just, but also the microbiologists and haematologists as well, not just, your SHO is not the go-to person in an emergency situation. They're often in these situations in a learning capacity as well. So you want your senior help here. You want senior midwives, extra midwives to help you manage the situation. And as I say, certainly for septic shock, you want your registrar and your consultant. Anaesthetists and ODPs may be necessary depending what it is that's causing it. If it's a retained products, they might need to go to theatre, or an abscess may need draining. And you may or may not need porters, depending on your hospital systems, to run samples for you. And as with every emergency, you need somebody to scribe for you. So you want someone to be scribing who's there, what they're doing, any drugs that are given, any manoeuvres, and you will transcribe those events, adding your rationale into the appropriate notes, because they will be kept for 25 years. And as I said, you've got your sepsis 6, you've got that 1 hour window. So let's think about our management. So keeping our top to toe A to E or F approach, we're looking at the airway. Okay, so what's her level of consciousness? Does she need to have that airway actually maintained by a head tilt chin lift? Or is she talking and just needs a bit of support with her breathing? Either way, we need to put that facial oxygen on at 10 to 15 litres, so high flow facial oxygen. You're expecting her respiration rate to be going up and her saturation levels to be going down, but the application of that facial oxygen should help maintain her SATs above 95%. Her circulation, you're expecting that pulse to be increasing as she's trying to compensate, and eventually that blood pressure will drop, and that's usually due to that vasodilation. And her capillary refill initially probably won't be too much affected, but as time goes on, then you are going to get a delay. Her consciousness level, again, might be affected, and also it's worth taking a blood glucose at this point. With septic shock, obviously temperature is not a big indicator. It may be high, but equally, as we've said, it may be low. And you'll document all your findings on an appropriate MEOWS chart or HDU chart, whichever you use in your trust. So thinking about delegating, so midwives, SHO can get some IV access. Okay, we need 2 wide-bore cannulas because we want to get some fluid in there, and we need to get some bloods out. So we will take the normal range of bloods, but because this is sepsis, we need to get some blood cultures, we need a CRP and a serum lactate, which are all specific to infection. They're infection markers. Okay, so we need to get those ideally before antibiotics start. And you might do some arterial blood gases, but she is likely to be acidemic. Okay, we need to put a litre of crystalloid up, so something such as Hartmann's. But remember, we're not just pouring fluid in here. Because of what's happening, her circulating volume is reducing because fluid is escaping from the blood vessels into the interstitial spaces. It's not being lost from the body. So really a 500 ml fluid challenge over 15 minutes, or more accurately 30 mils per kilo, should help improve, should reduce the serum lactate levels and improve the blood pressure. Okay, if it doesn't, they may well need to go to intensive care unit, and they may need drugs such as, some of the vasopressors to actually help improve that blood pressure. Obviously, midwife or students or the SHO can do observations, regular observations. They could put the catheter in. Remember, we want our hourly bag, and it needs to be quite careful fluid balance. So we need to document on a fluid balance chart quite accurately. And once we've done that, we need to be thinking what's actually caused this infection. And don't make assumptions. You know, somebody may have come in post-cesarean section not feeling well, and you make the assumption that it is her cesarean section that is the problem, but actually it may not be. So do take a top-to-toe approach, okay? Think more globally than just maternity as well. Don't think just midwifery stuff. So thinking about taking a throat swab, MRSA swabs, high vaginal swabs, any wound site she's got, take a swab from. If there's a cannula site there, take a swab from that. Either get a midstream specimen of urine, or if she's been catheterized, a catheter specimen of urine. If she's got diarrhea, we're going to need a stool sample. If she's got a productive cough, we're going to need a sputum sample. And once we've sent those bloods, get that broad spectrum IV antibiotic in. Do be mindful of allergies as well. But if you can't get someone to get the blood cultures, don't delay giving the antibiotics. Really, we need to get those antibiotics in ASAP, because that is going to give them the best chance of survival. And once the results come back from the microbiologist, you can change that, or the doctors will change that broad spectrum antibiotic to something that's more specific to whatever it is that's causing the problem. As I say, there might be some surgical treatment required if it's a drain, an abscess that needs draining, or if we need to go to theatre because there's retained products. We've said already about early involvement of the multidisciplinary team and early referral to ITU, because most of us midwives, or most midwives now, are direct entry midwives, so very few have actually got a nursing background. So really we need to be sending these women to where the expertise is. And whilst we do have very good training in high risk care, we are not intensive care unit nurses. So if these women are really sick, we need to send them to places where the teams that can manage them best are. That doesn't, if they do go to ITU though, that doesn't negate your responsibility as a midwife, because you still need to ensure that obstetrically she is well, even if the sepsis is not anything to do with the midwifery elements. So you would still need to ensure that someone goes to see her in that intensive care unit. And obviously we need to have conversations with family around the baby as well. So possible consequences of sepsis, well, as we've said, if there's continued tissue hypoperfusion, we might have some sort of organ dysfunction going on, particularly the kidneys. And if she is very unwell, if she has septic shock and she does need to be transferred to a high dependency unit or an intensive care unit, then you've got separation from the baby, which effectively may have an issue on bonding and lactation. These can be quite traumatic events. So she is at risk of post-traumatic stress syndrome, and she may need to debrief after the event. And women with sepsis, obviously, if you're thinking about all the pathophysiology of how that sepsis and septic shock is developing, it does put her more at risk of venous thromboembolism, so VTEs. So really you need to be thinking about, how can I minimize her risks? And that may well be the application of TED stockings. She may need some sort of things like Clexane or Deltaparin. You will need to score these women individually so that you make sure that you are treating them appropriately. They're likely to have a hospital stay that is longer than the average women. And of course, obviously with septic shock, death is always a possibility, but as those 11% in the MBRRACE report do highlight, but hopefully if you treat this swiftly and systematically, then that will not be an outcome. If she's come back in, or even if she's in the hospital, we may need to consider liaising with the paediatricians to see whether or not the baby needs a septic screen as well. And the partner is going to need some support, because particularly if his partner's been taken to intensive care or high dependency unit, she's not going to really be in a fit state to be caring for a newborn baby. So it is likely that he is going to need some support. And there we have it, sepsis. I hope you found it useful, and if you haven't subscribed to the channel, please do, and I look forward to seeing you next time.